Hi everyone, my name is Dr. Faisal Jahangiri, and today I'm going to talk about intraoperative neurophysiological monitoring. So I'm just going to give you an overview about what is IONM and what are the benefits and what are the application of IONM in surgical field. So intraoperative neurophysiological monitoring, which is also referred as IONM or IOM, it is an application of different techniques in high-risk surgical procedure to minimize the post-operative surgical deficit. This is just about my background, my experience in neuromonitoring and the medical background. So what is IONM? So intraoperative neuromonitoring is a continuous monitoring of patient nervous system, including brain, brainstem, spinal cord, or peripheral nervous system during high-risk surgical procedure. The purpose of IONM is to protect the nervous system during these surgical procedures. Technically or typically, what we have to do is when every time the patient is going for surgical procedure, the surgery may last for 1 hour, 2 hours, or it could be 15 or 20 hours long. We have to wait until the end of the surgery to see if the patient wakes up and have no deficit. And these deficits could be sensory deficit, motor deficit, hearing deficit, visual deficit, or memory loss. And it all depends upon the type of surgery, location of the surgery, and what can happen during the surgery. If the patient cannot move the legs, or patient cannot hear, or have a decreased power in muscle, we have no idea what happened at what time. So we can guess about different factors that can cause that. But it's always, most of the time it's too late, and we can go back and decompress and open the surgery and look at the structure to see if we can fix it. But when the change happens after many hours, it's impossible or very not easy to go and fix that. So in order to prevent that, we can do different type of testing while the surgeon is operating on the patient, and we can identify. And we have signals which are transmitting to the surgical site, and if there's a change, we can identify and we can inform the surgeon, and surgeon can create a different type of reversible procedure that can minimize that. So if you make the changes within few seconds or few minutes, then those are more preventable. So we refer them as high-risk surgeries, but most of the surgeries, the patient consider them high-risk surgery every time they go under anesthesia. So some of the surgeries where there's a high risk of damage or that can cause post-operative neurological deficit is one of them is scoliosis. Scoliosis is one of the very common surgery which is done all around the world, and the patient's spinal cord is curved and you have to go and correct that. So when you are trying to correct that, there's a risk of stretching the nerves or spinal cord too much. So we can see the spinal cord, but we cannot know how much stretch that the spinal cord can hold. So it could be 95% correction, it could be 60% correction, it could be 70% correction. So in order to wait until the end of surgery, or previously there was a special test which was called wake-up test. We place all the screws and rods and then wake up the patient and ask the patient to move the legs. And if the patient can move the legs, that means everything is okay, and then close. But that's after all the screws and all the implants are placed. So instead of that, so we can do the testing while the surgeon is placing the screws or rod on instrumentation, and we can inform in real time. And these surgeries can have significant effect on lower limb motor function, sensory function, and bowel and bladder function. So these patients are at risk of these sensory, motor, and bowel bladder function. Spine trauma or another, so any spine trauma or tumors or subluxation, any kind of surgery on cervical spine or thoracic spine can also cause post-operative neurosensory motor deficit and also result in bowel and bladder function. If a patient has a brain tumor, and you are going for a brain tumor resection, all the sensory area, motor area, which controls the body, and also language area, Broca's, Wernicke's, they are also could be in that region. And if there's a damage to that area, patient will not be able to move or have no sensory function or can have loss of speech or memory. So we can, all these structures at risk during surgical procedure, which can be monitored. For brainstem tumor or posterior fossa tumor, for example, cerebral CPA tumors, facial nerve and all the lower cranial nerves are at risk, auditory nerve as well as 9, 10, 11, 12, all the nerves are at risk. And that can result in facial paralysis or hearing loss or other problems. So these can be monitored during the surgeries and can be minimized. So let's go and talk about these different tests. So this is an illustration that if there's a surgical site, and what we do, we treat the nervous system as an electrical circuit. So if you stimulate this from one side, you can get a signal from the other side. It could be an electrical signal, it could be auditory signal, it could be visual signal, it could be sensory stimuli. But we can elicit by different stimulation. So if you stimulate one, and if the signal transmits through the surgical site without any change, that means everything is going fine. If there's an injury or pressure to the surgical site or the neurons or the nervous tissue passing through the surgical site, then the signal will decrease in amplitude or will disappear, and that need intervention. So that can be done in real time and can be very beneficial for the patient and for the surgeon. So we can do an intervention when there's a loss of signal or decrease in the signal or even delay in the signal. The signal takes the normal time it takes the signal, it takes longer to get there. That means something wrong due to pressure on that. So the patient has no IONM during the surgery, or patient has poor IONM function. Somebody is doing IONM but they are not trained to do that. So well-trained people are required, and experience has people. The team with more experience will have less postoperative deficit as compared to a team with no deficit, with no experience, or team with less experience. So a patient, if there's a good IONM or a good expert team in IONM, the patient will have less postoperative deficit, and that could be in any type of surgical procedure. So interpretive monitoring has a better patient outcome by minimizing the risk related to the functional status of the nervous system during surgical procedures. An IONM alert to surgical team during these surgical procedures can help them identify the changes and make an immediate action to reverse this procedure. So when they can do that, so they can minimize the postoperative deficit. So we would like to learn about different advantages of IONM and also put which may be possibility of medico-legal complication. So the term neurophysiological monitoring is defined by American Society of Neurophysiological Monitoring, also ASNM, as any measure that is used to assess the functional integrity of the central or peripheral nervous system, either in the operating room, ICU, or any acute care setting. So that's the definition which is provided by ASNM. So what I'll do, neurophysiology is a very broad term and it has a different application. So it's much easier if you can split into 4 major categories. And the first one is diagnostic neurophysiology, which is very common and most people are aware of that. So diagnostic neurophysiology is the utilization of these testing procedures to diagnose an underlying disease. The patient has history of seizures, so we can do EEG. The patient has a multiple myasthenia gravis, so we do EMG, or a patient has hearing deficit, we do auditory evoked potential. So all these different, like for epilepsy, multiple sclerosis, myopathy, hearing loss, visual loss, intracranial vasospasm, stroke, so we can do translated Dopplers. So all these testing is done to diagnose the disease. So that will be a diagnostic neurophysiology, which is done in outpatient and clinical awake patient. It can also be done in other locations, in the doctor office as well. So the second category we talk about is prognostic. Prognostic is we use the same techniques to see the patient is getting better or worse. So the patient is getting, so if you do neurophysiological testing, sensory evoked potential or auditory evoked potential every 6 hours or every 8 hours, in a patient who is under in coma or in ICU, we can tell the patient is getting better or worse and what will be the prognosis of the patient. Many patients, like 10, 30 to 15 to almost 30% patient, they can have an underlying subclinical seizures while they are in ICU. So patient is not physically convulsing, but the brain is continuously firing. So if you do EEGs in these patients, you can identify which patient is having subclinical seizure, which can have a damaging effect on the brain, and treat them without any clinical presentation. Therapeutic neurophysiology is another category where we use these techniques to treat the patient, or for a therapeutic, for such as Parkinson's disease, stroke, trigeminal neuralgia, failed back surgery syndrome. So for example, for Parkinson's, we use deep brain stimulation. So deep brain stimulation is a technique where we identify the target nucleus and then implant an electrode which treats the tremors of epilepsy, of Parkinson. So deep brain stimulation is FDA approved for Parkinson, essential tremor, dystonia, obesity, OCD, epilepsy, etc. Pain implant for pain can be also done for brain and spine. So a patient with severe pain in the face, trigeminal neuralgia, if it's not treated by Botox injection or ganglionic block, so you can identify the face area and localize and place and grid and attach to the battery in the chest, and that battery cause numbness, paresthesia in the face, and relieve the pain. Same as patient who go multiple surgeries in the spine and they're diagnosed as failed back surgery syndrome. We can do a spinal cord implant, stimulator implant, and in order to do that, so we can use EMG, motor evoked potential, and sensory evoked potential, different testing to localize the area which patient is having pain for right leg or left foot, and then place the implant there so patient has numbness in the area and the patient is relieved. The last one, which is the main focus of our presentation today, is intraoperative neurophysiology, also known as surgical neurophysiology. So we have diagnostic neurophysiology, we have prognostic neurophysiology, we have therapeutic, and then we have intraoperative. The purpose of intraoperative is to make sure when the patient comes to the operating room, they don't leave the operating room with any more deficit. So if they have any deficit, we cannot improve that. But if they don't have a deficit, patient should not have any either no deficit or no further deficit, and minimize any risk of that. Done by minimizing any pressure, the damage done by mechanical insults or chemical or ischemic or heating can also cause damage to the nerve. So we can identify that and prevent that during the surgical procedure. So IONM industry has grown very significantly in last 10 years, 20 years, and it's growing at the rate of about 8 to 10% every year. And there's a still need of trained neurophysiologists and technologists, because we have thousands of hospitals and we don't have enough technologists and neurophysiologists. For technologist level, the exam is CNIM, certification in intraoperative neuromonitoring, which requires minimum of bachelor degree, and some people can be grandfathered into that if they don't have bachelor degree with the experience and other certification. But so far, there are about 5,000 people who have been certified in the last 30 years, and many of them, either they are in management position or they are retired or they are not working as that. At the doctoral level, the certification is American Board of Neurophysiological Monitoring, and also American Board of Clinical Neurophysiology have subspecialty intraoperative monitoring. So the American Board of Neurophysiological Monitoring, ABNM, there are only about 136, 137 people who are certified all over the world. So there are not even one neurophysiologist with ABNM in every single state. So IONM is very beneficial for different surgical procedures that include neurosurgery, orthopedic surgery, vascular surgery, ENT surgery, cardiac surgery, interventional procedures for coiling, angioplasty, some of the genitourinary procedures. We have techniques to do monitoring for prostate surgery and also colorectal surgery to minimize any deficit. and also general surgeries. So some of the general surgeries where the nervous system is risk can be helped. So IONM industry as a whole industry, it is being used in all over the world. So in the US there are three kind of mixed markets or applications. One is hospital-based service, which is that the hospital has employed, or they have a department which is covering the intraoperative monitoring by a dedicated neurologist or neurophysiologist and technologist team. And the neurologist is in the hospital and they come to the operating room and they'll oversee patient to patient. The second model, which is a big chunk, is private companies. So they're private subcontracted companies. They contract with the hospital who don't have the neuromonitoring capabilities or difficult to hire people and train people and keep on the. So they provide contract service to hospital and as needed basis. So the technology are working from home or they have an office and they are assigned different cases every day. And the physician who's online is remotely connected to the online. So the physician is not in the OR. They're committed for a dedicated HIPAA compliant line and they're looking at the data via remote server. The third one is combination of those two. So the hospital-based physician who are also looking via remote connection. So they are not in the OR, but they are in the office. But if they are needed, they can walk into the OR anytime. So this is a very good article which was recently published by American Society of Neuromonitoring about practice guidelines for supervising professional during the intraoperative neuromonitoring. So if anyone interested, so I'm one of the author on that too. So if anyone interested, so you can go to the IONM website and download the article for more detailed information. So again, the physician oversight, so that the technologists, they're always in the operating room and they are responsible for connecting to the patient, collecting the data, and looking at the data and communication with anesthesia and the surgeon and the nursing staff. And they also are responsible for connecting to the neurologist, and the neurologist is supervising by two ways. Either they are in the hospital, present physically in the OR, or through the remote connection, or they are remote out of hospital connection. So that's the majority of the physician oversight is done by remote internet, and they are monitoring multiple cases at the same time. And so if there's a special attention needed for special cases, then they have to have a dedicated attention for that special surgery. There are different societies. So if you want to be part of the neuromonitoring, there are national societies, there are regional societies, there are state societies, and then international societies. So the national societies where focus on neuromonitoring is one of the largest societies, American Society of Neuromonitoring, IONM. And they have regular membership, they have also student membership, and which is also include the membership for resident and fellows. So if you are a fellow or resident or degree student, undergrad, grad, or PhD student, you can apply as a student. American the Neurodiagnostic Society of ASSET is the other large organization, which has members for EEG and IONM, both of them. So their meeting and their focus is more broader than IONM. IONM is just the intraoperative monitoring, where ASSET also has membership for clinical neurophysiology as well as EEG and long-term EEG. American Clinical Neurophysiology Society is also a physician-based society where non-physician can be member, which has members for all different type of neurophysiological monitoring, from ICU, clinical, intraoperative, and everything. So just have these. If anyone want to become a member of IONM, so they also provide webinars, free webinars for their members, and you can enroll them. And those webinars are You get CME and CEUs for that, and that can be used for your examination for CNM or ABNM. Asset also provides webinars with a nominal fee for members, and it has a bookstore which also have that. This is the website for our ACNS website. And then we have regional societies. One of the multi-regional society is SSET, Southern Society of Electroneurodiagnostic, which has provide information between technologists, lab managers, and it has multiple state members, and they do annual program and meetings. Then we have regional societies, so Texas Society, California Society, so they are state-based societies, so you can be, depending on which state you are, and you can be. Then we have international societies, so International Society of Intraoperative Neurophysiology, ISN. So this is one of the largest intraoperative neuromonitoring based society, and they have every 2 years, every year they have different meetings, and they move around the world. So every year there's a different meeting in a different country. We also have examination body. So if you want to be in this field, so you can take the examination board, and one of the board is ABRIT, American Board of Registration for Electroencephalographic and Evoked Potential Technologies, which administer different tests. The second for board level is American Board of Neurophysiological Monitoring. So if you want to take American board, you have to have MD or PhD with 300 surgery plus 3 years of experience, and you take written part and oral part. For CNIM, you just need a written part. There's no American ABCNN or American Clinical Neurophysiology Society also have examination, and then it's a 2-part exam. Part 1 is general neurology, and part 2 you can have subspecialty as in intraoperative neuromonitoring or epilepsy or general neurology or movement disorder or some other. But in intraoperative neuromonitoring is, so you have to take those 2 exams, 2 written exams, part 1 and part 2 for that.